Welcome back to Microbiology in Primary Care. I'm Dr. Sarah Mitchell, and as always, I'm joined by Dr. James Whitaker. Today, we're diving into Mpox, formerly known as monkeypox, and what primary care clinicians need to know, especially in light of recent outbreaks.
Thanks, Sarah. Mpox it's a fascinating virus from a microbiology perspective. It's a zoonotic orthopox virus, which means it's primarily an animal virus that occasionally jumps to humans. The origins are a bit murky, but the first isolation was in monkeys in 1959, though the first human case wasn't until 1970 in the Democratic Republic of Congo. Despite the name, monkeys aren't actually the main reservoir. African rodents like squirrels and rats are much more likely culprits.
Yeah, and I think that's a common misconception. People hear monkeypox and immediately think of primates, but it's really these small mammals in forested regions of Africa that keep the virus circulating. And James, can you walk us through the structure of the virus? I always find the brick-shaped description oddly charming for something so, pathogenic.
Absolutely. Under electron microscopy, pox viruses are quite distinctive. Brick-shaped, about 200 to 250 nanometers, and they've got this lipoprotein envelope. What's remarkable is that the Mpox virus carries a linear, double-stranded DNA genome, and, unlike most viruses, it brings along all the proteins it needs for replication, transcription, assembly, and egress. It only borrows the host's ribosomes for mRNA translation. It's, a bit of a control freak, if you will.
That's a good way to put it. And of course, there are two major clades we talk about, the Congo Basin and the West African. The Congo Basin clade is more severe, right?
Yes, the Congo Basin clade, sometimes called the Central African clade, has a higher case fatality rate, up to 11% in unvaccinated children, if I'm remembering correctly. The West African clade is less severe, with a case fatality rate below 1%. And interestingly, the 2022 outbreak that's been making headlines is linked to the West African clade, which is, I suppose, a small mercy.
Right, and the transmission patterns have shifted too. Historically, it was mostly animal to human, but now we're seeing more human-to-human spread, especially through close contact, respiratory droplets, and, as we'll discuss later, sexual transmission.
That's true. And speaking of animal reservoirs, I remember a trip to West Africa a few years ago. I was photographing wildlife, and I kept thinking about how difficult it is to actually pinpoint which species are maintaining these viruses in the wild. You see a squirrel or a rat, and you have no idea if it's carrying Mpox. It's a bit unnerving, honestly.
I can imagine, and it really highlights why surveillance and understanding the ecology is so important. Okay, let's shift gears and talk about what happens when Mpox actually infects a person. How do we recognize it in the clinic?
So, the clinical picture starts with a prodrome: fever, headache, muscle aches, fatigue, and crucially, lymphadenopathy. That's swollen lymph nodes, and it's a key feature that helps distinguish Mpox from smallpox. I always tell trainees, if you see a vesicular rash and lymphadenopathy, Mpox should be on your radar.
Absolutely, and the rash itself is pretty characteristic. It usually starts in the mouth, then spreads to the face and extremities, including the palms and soles. The distribution is what we call centrifugal, so more on the face and limbs than the trunk. And the lesions evolve synchronously, which is a fancy way of saying they're all at the same stage at any given time. That's different from, say, chickenpox, where you see lesions at all different stages.
Exactly. The lesions go from macules to papules, then vesicles, and finally pustules. They're firm, deep-seated, and range from about 2 to 10 millimeters. After about 5 to 7 days, in the pustular phase, they crust over and eventually fall off. Patients are considered non-infectious once all the crusts have fallen off. It's a long course, 3 to 4 weeks typically.
And you know, I had a case a while back where early recognition of lymphadenopathy made all the difference. The patient had just returned from Nigeria, and the initial symptoms were pretty nonspecific: fever, malaise, that sort of thing. But the lymph nodes were really prominent, and that tipped us off to isolate and get the right tests done quickly. It probably prevented further spread in the clinic.
That's a great point. Laboratory confirmation is essential, especially since the clinical presentation can overlap with other conditions. The CDC recommends collecting 2 specimens from multiple lesions in different locations. PCR is the gold standard for detecting Mpox DNA, but you can also use electron microscopy, immunohistochemistry, or serology for orthopox virus antibodies. PCR has really improved our diagnostic accuracy. Before that, it was a lot of guesswork and, frankly, a bit of luck.
Yeah, and I think it's easy to underestimate how much these advances have changed outbreak control. Rapid PCR means we can confirm cases and start public health interventions so much faster. But of course, you still need to think about the clinical context, travel history, animal exposures, and so on.
And just to add, in the 2022 outbreak, we've seen a lot of cases in men who have sex with men, with lesions clustered in the genital and perianal areas. That's a bit different from the classic presentation, and it's a reminder that the clinical picture can shift depending on the transmission dynamics.
Exactly. So let's talk about what we can actually do for patients. How do we manage Mpox, and what have we learned from recent outbreaks?
Well, unfortunately, there's no specific clinically proven treatment for Mpox. Management is mostly supportive, so isolation, symptom control, keeping lesions covered, and monitoring for complications. For severe cases, there are investigational antivirals like tecovirimat and brincidofovir, but their efficacy in humans isn't fully established. Sometimes, vaccinia immune globulin is considered, but again, the evidence is limited.
And prevention is really where we can make a difference. For high-risk exposures, post-exposure vaccination with the modified Vaccinia Ankara, or MVA, vaccine is recommended. It's a 2-dose series 4 weeks apart, and it's much safer than the old smallpox vaccines. If you can get it within 4 days of exposure, it may prevent disease entirely, and up to 14 days, it can reduce severity. Plus, it doesn't cause a skin lesion, so there's no risk of spreading the vaccine virus.
That's a huge advantage, especially in immunocompromised patients. And as you mentioned earlier, the 2022 outbreak has really highlighted the role of sexual transmission, particularly among MSM communities. In Spain, for example, 99% of cases were in men who have sex with men, with lesions predominantly in the genital and perianal regions. That's changed our public health messaging and our approach to contact tracing.
Yeah, and it's also brought up new challenges in primary care. We're seeing more patients with complications, scarring, bacterial superinfections, even rare cases of encephalitis. So it's not just about the acute illness, but also about monitoring for long-term effects and supporting patients through isolation, which can be really tough.
Absolutely. And in primary care, we're often the first point of contact, so recognizing the signs early, isolating appropriately, and coordinating with public health is critical. Monitoring symptoms for 21 days after exposure is the standard. And, well, it's a lot to keep track of, but it's essential for outbreak control.
I think that's a good place to wrap up for today. Mpox is a complex disease, but with vigilance and the right tools, primary care can play a huge role in controlling outbreaks. James, thanks for sharing your insights and your wildlife stories as always.
Thank you, Sarah. Always a pleasure. And thanks to everyone listening. Stay tuned for more on emerging infections in primary care. Take care.
Bye, everyone. See you next time.